Today I speak about suicide prevention in older persons, and in my presentation shortly I will speak about key statistics on suicide, then statistics on suicide in the Republic of Serbia, older people and suicide risk factor, then very important, especially now, COVID-19 and related risk factor, and the main and the most important part is prevention and intervention. Approximately 800,000 people die due to suicide every year. For every suicide, there are many more suicide attempts. A prior suicide attempt is the single most important risk factor for suicide in the general population. 78% of global suicide occur in low and middle income countries. Ingestion of pesticide, hanging, firearms are among the most common methods of suicide globally. The lifetime risk of suicidal ideation is 30.5%, and the lifetime risk of suicidal ideation with the plan is 3.9%, and the lifetime risk of suicide attempts is 4.5%. The risk of suicide attempts in males is around from 1.3 to 3.8% per year, and for the women is from 1.5 to 10%. Suicide, we need to be aware that suicide is a major public health problem. Around 90% of patients who died by suicide denied suicidal ideation during their last communication with the hospital or healthcare provider. When we speak about Republic of Serbia, the latest data from 2015 shows that the rate of suicide in Serbia 15 is higher than in European Union 13.8. The rate has been steadily declining for several decades, in line with the global trends, and has declined from 20.9 in 1997 to 15 in 2015. When we speak about older person and suicidal risk, World Health Organization statistics from World Health Organization shows that suicide rates tend to rise as a function of age for both men and women. In the United States of America, older adults only account for 12% of the population, but they account for 18% of suicide deaths. Older people from 75 to 85 years old have higher rates of suicide than those who are between 65 and 75, and individuals 85 or older have the highest risk. More than half of those who die by self-inflicted harm, 54%, have they didn't have any mental condition. On the positive side, the rate of suicide among older persons, while higher than the rest of the population, declined faster as well. Men are far more likely to commit successful suicide attempts. In United States of America, 84% of those with no mental health condition are typically male, and 69 of suicide among those with mental health issue are also committed by men. And we need to be aware about one phenomenon and called silence suicide. Silent suicide is overdose, self-starvation, self-dehydration, and accidents among older persons. Also suggest that the rates for demographic and underreported, in some estimation by 40%. In Serbia, the trends are same as the rest of Europe, and the risk of suicide increase with the age. In 2005, 50% of all suicide victims were over 60, and one third was over 70. Then in older people age from 80 to 84, there was 69 per 69 deaths of suicide per 100,000 people in 2005, and this one over 85, it's 84.1 per 100,000 people. When we speak about risk factors, first of all, that previous suicide attempts are the main risk factor of suicide. Then adverse childhood experience, stressful life events, family history, both of suicide attempts and psychiatric pathology, recent suicide attempt by friend or by family member. Social isolation is risk too, psychological stress, availability of means, and low education or income levels. That's a risk factor, but risk factor in older age, we have first elder abuse, financial loss, social isolation, cognitive impairment, incapacity, medical illness, physical impairments, and other impairments to independent living, loss of the partner. Then divorce. Divorce is a risk factor, especially for older men. Barriers to seeking help, social, institutional, individual, underutilization of mental health services, and overlooked of depressive symptoms by healthcare professionals, chronic pain, forced institutionalization, then ageism, and self-neglect. We need to speak about COVID-19 and related risk factors because COVID-19 risk of suicide increased during an epidemic. We saw that The Spanish flu epidemic was associated with the increase in death by suicide. The outbreak of SARS in Hong Kong in 2003 was associated with significant increase in suicide deaths among older people age 65 plus. Decrease in social integration and interaction during the epidemic and fears caused by epidemic are a big risk factor of suicide. If we speak more specifically for COVID-19 pandemic, the risk are as first social isolation, anxiety, fear, and uncertainties. And the people who are more vulnerable and more in risk is person with the pre-existing psychiatric disorders, person with low resilience, person residing in a high COVID-19 prevalence area, and person who have a family member or friend who has died from COVID-19. We speak about risk factor, but very big thing is protective factors. That's social connectedness, access to the utilization of mental health services, skills of coping and adapting to change, physical activities, and internal locus of control. If we want now to speak about protective and preventive strategies, we need to be aware that access to the both regular and mental health care services is crucial in suicide prevention. The role of general practitioners in recognizing the early warning signs of suicide ideation, as well as the condition that may lead to it, such as depression, should be emphasized, as they are the ones in direct contact with the population and may significantly contribute to recognize the suicide risk. On the other hand, they also may be very instrumental in ensuring that person who do have some symptoms that demands further explanation and therapy are informed, encouraged, and supported in seeking and receiving specialist services. General practitioners should be the one to encourage help-seeking behavior in their patients, especially men who are less likely to do it. That's first step, because older people going to the health care practitioners and they trust in them, and because of that they need to be this first step to referral if someone need more. Then regular screening along the same lines, it is important to introduce routine screening for different mental health issues, but above all for depression. In a large part, this is important due to the against prejudice that exists even among healthcare professionals that makes depressive syndrome normalized and thus often overlooked, which can lead to them worsening and increasing suicide risk. Subclinic form of depression in older person especially should not be overlooked, since if under if if they are not perceived very well, they may worst and lead to increase the risk of suicide. Identifying the condition and underlying risk early is significant, and it's important that chance that treatment will be successful, and this does contribute to prevention of suicide. Then tackling social exclusion and social isolation. Today we talk about epidemic of loneliness among older person, and this is what also significantly contribute to suicide risk in this population. This needs to be addressed to different forms of social intervention among other things. This intervention can be done at community level and through develop easily scalable, cost-effective programs of including older person in community activity. Risk of suicide is decreased in addition to other positive effects of social inclusion of older persons. Such intervention can be widespread and include as many older people as possible, but there should also be tailor-made approach that should targeting groups in a higher risk, such as older people living alone, person with functional impairment, survivors of elder abuse. We need to think about these people who are in a higher risk of suicide. The intervention can be implemented by civil society organization, faith-based organization, in order to use the sources effectively and efficiently as possible and avoid overlaps. Then another thing is telehelp SOS suicide prevention telephone line. These prevention modalities are important because they are easily scalable and continuated the first step for someone who decide to seek help. Therefore, the societies, including the governments, should make a commitment to support these modalities and not leave everything just to the civil society organization. Also, providing support via telephone and other remote means is a very high importance for older person, especially if they have mobility difficulties or live in an area far away from healthcare and other support institutions. And we need to have telephone, maybe one telephone line on a national level or in a local level just for older person. Then peer support groups. Peer support groups help people to understand that their problems are not unique and that they share them with others, as well as that they can be addressed and solved. Peer support groups need to be supported by society as well as recognized by healthcare professionals as available asset in suicide prevention. During the Red Cross of Serbia has a peer support group for older people, But during the COVID, we started with telephone help or telephone cycle because older people during the emergency situation forbidden to go out, and then they start to talk by telephone, and that something was very successful because they help each other as a peer support through telephone. That then another preventive strategies is access to palliative care and pain management. Special attention must be paid to the pain management and in healthcare, and chronic pain may be one big risk factor for a person already at risk of suicide due to the other factor. Therefore, palliative care services are very important segment of healthcare for older population. And then addressing the ageism and prejudice, prevalenting attitude and that older person are burden to their families and the society mean that allocation of resources in different segments of care and support services may be may be inadequate, and this reduce the capacity of those systems to be effective and prevent suicide. On the other hand, this affect older person sense of self-worth may they self-esteem and lead to increase of depressive symptoms. Therefore, fighting and from fighting therefore, fighting and suppressing toxic attitude based on ageistic stereotypes and prejudice is important on several levels and is an important element of suicide prevention. We need to involve older people in all our preventive strategies, and we need to ask older people when we design some policy activities and everything we are doing. Thank you very much for your attention. If you have any question on screen, you have my email. Thank you.